Okay. See, you show the Shirodkars, I will show the McDonald's, okay? Which we put it up in the group. All right?
Sure, sure. You start.
Yeah. Good morning, everyone. Today's masterclass is on cervical and cerclage, which was requested by many, and we have posted videos of the same in our WhatsApp groups. So today's will be mainly on the surgical technique, which Dr. J and I will be sharing. Sir is in Chennai operating today, and this class is, I think, the need of the hour because I think many young gynecologists would want to know exactly how it is done. So over to you, sir. You can start off.
Yeah. So see, in this class, we are going to focus only on vaginal cerclages. Cerclages through the vaginal route. We have a class on laparoscopic cerclage, which we are going to be taking on Friday. Okay. So I will start off with my screen sharing. Shilpa madam, just stay on the line. Okay. Yeah. Can you see my screen?
Yes, yes.
Okay. Now, fine. See, this is a modified Shirodkar Cerclage which I am demonstrating for a previously done McDonald Cerclage. Can you see that? The McDonald stitch you can see has been taken, and I'm just cutting it off because there was a funneling which had happened at the level of the internal loss. So there are two things. One is therapeutic, one is rescue. Okay, prophylactic, all these categories. See, the first thing in order to put a modified Shirodkar Cerclage is to identify the junction between the vagina and the cervix. The simple maneuver which you can do is push the cervix in and out. So the region where the vagina has a fold, okay, that is the junction. So you infiltrate normal saline. This is simple normal saline which is infiltrated. Take sharp scissors and just give small cuts there. Okay, because see, this is already very edematous tissue, already very vascular tissue. All right, you really need not open the UV fold here. Please remember that. This is just done to ensure that your knot goes high up. You are not doing this procedure to ensure anything else in life. Okay, your knot should go as close to the internal os as possible, because internal os is the one which has the maximum capacity to hold on to the pregnancy. So you can see that that part of the vagina from the cervix is separated. Use the anterior speculum, sim speculum, to separate it even further. Just see that that is the cervix. You can palpate it with the scissors and you will be sure that it is the cervix. Now, if in case you are encountering any bleeding there, just apply compression over it. That bleeding will automatically stop. Okay, I am using here sponge holders. Yesterday I showed you with Alice forceps. Both are equally good. This is a Mercilin tape. You can see on my finger there is lignocaine jelly which I have applied. So this Mercilin tape is then coated with a lignocaine jelly. Okay, and you can have these stitches in two manners. You can either go antero-posterior, or see what I'm doing here. Take one stitch in that anterior. What this does is it buries that particular part of the knot there. I mean, it buries that particular tape in that region. So once that tape is buried in that region, you take it out. This is the easiest anti-clockwise suture which you can pass, to be very honest with you. Rest of the sutures have very limited space. So what you are supposed to do is you are supposed to maneuver. Okay, you are supposed to maneuver and create space in the vagina with the help of your speculum. Okay, so see that needle has come out there. That needle will be posterior. Now remember one thing, we are not opening the posterior pouch here, but if it is necessary, and if the cervix is really short, there is absolutely no harm in dissecting and opening the posterior pouch. This is a place where we have not opened it, but we routinely open it when we feel the need for that, because you want a minimum cervical length through the internal os to be at least 3 centimeters in order to maintain something good and in order to allow the pregnancy to continue very nicely for the patient. Okay, that is something which you have to keep in mind. So see, once that tape is out, what has happened is that posterior speculum. Can you see that? Now, apply good downward pressure with that posterior speculum. See that speculum goes behind, and apply pressure down towards the anus. Okay, That is something which is important. That will automatically create a good amount of space in the posterior vagina. Okay, this is a mistake which people make. Often people are not able to do it. Remember, maneuverability here is important because these are large size needles. The Mercilin tape needle is a large needle. Large needle, small space. Okay, so whenever there is large needle and small space, that means your retraction has to be good and your maneuverability has to be good. Okay, and then you take the final stitch just like that. Okay, from the opposite, because there are two needles inside it. Since this Mercilin tape is coated with lignocaine jelly, it will pass through the cervical stroma very nicely. Okay, you don't need to have ultrasound guidance to pass this. All you need to remember is pass it through the stroma. If you are passing it through the stroma, there will be some resistance to pass it. That is it. That is your guiding light. All right. If there is some resistance for you to pass it, you should be a happy person, because that means you have gone through the stroma very nicely. Any role of giving head low to the patient? While doing this procedure, we give head low by around 10 degrees. But remember, quite a lot of pregnant patients may or may not be very comfortable tolerating this very much high head low. Okay. After it is done, see that we don't close the anterior incision. If we take the posterior incision, we don't close the posterior incision as well. Okay. Patient is kept in the hospital for 24 hours following this surgical procedure. After 24 hours of the procedure, the patient is allowed to go back home. We do not provide any specific tocolytics. At the time of doing the surgery, we give the patient mandatory loading dose of atosiban, that is 6.75 grams as a push, bolus push. And after that, we give 37.5 grams over a period of 3 hours. That's it. Nothing else is provided to the patient. Single shot of antibiotic. And after that, we give 5 days of metrogel to the patient, because sometimes bacterial vaginosis can ascend upwards and can cause chorioamnionitis. So we just give metronidazole to these patients for 5 days. We do not give Proluton depot. We do not give any added progesterone to this patient, because all of that is not going to really work or help, because placenta is already formed, and by the time you are doing this, the gestation is close to 18 to 25 weeks. So all these things, that little 400 400 mg of progesterone or dufaston and all this is going to cause no benefit to that patient. Okay, so we have applied emergency cerclages vaginally up till 28 weeks, because that is the period of viability for the NICU. Your pediatrician is going to be the most happiest, even if he is the best pediatrician. Okay, once you give him a baby which is more than 30 weeks. Okay, because the outcomes for 30 weeks plus NICU babies is way higher as compared to outcomes of 28 weeks babies. Okay, so pediatricians really like 30 weeks. 28 weeks is like their cutoff. It's like, the gray area between doing abdominal hysterectomy and laparoscopic hysterectomy, something like that in NICU also, between 28 and 30 weeks of gestation. Okay, but remember one thing. When you are trying to do these technical points, okay, often people are wondering if to give general anesthesia or spinal anesthesia. So the answer is, you can give whatever anesthesia your anesthetist is comfortable with, as long as it is relaxing the vagina. Okay, we have done something like this in saddle block also, and even in saddle block it will work extremely well. So you don't really have to get worried about what is the best particular anesthesia for this particular patient. All right, that is one thing. Second, lot of times people say that if membranes are exposed in the vagina for an emergency cerclage, the outcomes are poor. The outcomes are not poor because of your cerclage. The outcomes are poor because of the ascending infection which has gone from the vagina towards the membranes, and it will cause the membranes to then rupture. So that is something which you have to then keep in mind. So this finishes my part of modified Shirodkar Cerclage. Okay, this will go close to the internal os. Remember, you will almost never be able to go accurately at the internal os. Should you be wanting to go accurately at the internal os, then definitely and without any doubt, the procedure of choice is going to be to go with a laparoscopic cerclage, which we are going to be describing on this Friday. Okay, in our surgical series with Dr. Aarti. But now I hand over the screen sharing to Dr. Shilpa, and let Dr. Shilpa also present her video, okay, of the McDonald stitch which she just took. Your screen sharing is enabled, Dr. Shilpa. Yeah, so after emergency cerclage, it depends, first 48 hours are critical, but then after that 48 hours, if the pregnancy is pulling on, we've had pregnancies going on till 35, 36, 37 weeks also.
See, are you able to see?
I am able to see you, I am able to see the video. Speak. Dr. Shilpa, your video is
Yeah.
playing.
Oh, sorry. I'll just, yeah. So this is the exposure of the cervix. I'm doing a prophylactic stitch wherein the patient has had previous mid-trimester abortion. So this is at around 13 weeks and after the NT scan and the double marker report. So I start at say 2 o'clock and come out at 12 o'clock. And I'm taking a pearl string suture here. So this is the same muslin tape which Dr. Jay has used. So the two stitches, I take it with one needle, and the other needle I go from say like 3 o'clock till 5 o'clock. And here you need to observe that the anterior speculum needs to be taken out once you're taking the posterior bite. So once the posterior bite is taken, I think this is the most difficult bite which can be taken. So here, as Dr. Jay mentioned, you need to expose the cervix by pressing on to the anus. And once you do that, so the important thing here is like don't enter the cervical canal. It should be like in the cervical tissue, and also the tape should be like the bite should be closer so that there is no large chunk of tissue there. So once you do this, tying the knot is easier and there is no tearing through. So here I have around, say, about 2 centimeters length. And usually I'm quite comfortable with the McDonald stitch for prophylaxis, unlike Dr. Jay, who does more of emergency cerclages. So once we do this, you can see here, like there is about 2 centimeters cervical length here. Even if there is little bit of bleeding, I think that can be managed with just a pressure. So, yeah.
Yeah, I think it is important to understand why people are insistent on Mercilin tape as compared to Mersilk sutures or Prolene sutures, right? See, Mercilin tape has a 5 millimeter width. Just remember that. Okay, so this 5 millimeter width is going to encompass and cause fibrosis over a much larger part of the cervical stroma as compared to the Mersilk. Understanding Mersilk is good when you are doing McDonald's, when you are not going till the os, it is between somewhere between the internal os and the external os. That is your McDonald's stitch. Correct. When you are taking Mercilin tape and when you are trying to do a modified Shirodkar, you are trying to go as close to the internal os as possible. So the amount of fibrosis which you have to generate there has to be maximized. And that is going to be possible with your Mercilin tape because of the sheer width of that Mercilin tape, which is 5 millimeter. Understanding? So that is something which you have to keep in mind when you are taking these type of stitches, that the width of the suture material is important. As a result of which, Mersilk is going to be better than Prolene and Mercilin tape is going to be better than Mersilk. Okay, when you are doing this particular technique. Okay.
The cost of this is how much? The Mercilin tape?
1,000 maybe. I think 1,000 rupees. Higher? 3,000. Sorry, not 1,000. 3,000. Sorry, 3,000.
Yeah.
So
So,
yeah, it is 3,000. Definitely. See, there is no question of asking Ethibond, Ethigore, Gore-Tex. Nothing comes in comparison. There is nothing which is a 5 millimeter suture. Okay. So 5 millimeter, the only thing which is available is a Mercilin tape. Okay. So just keep that in mind. Now, second thing which people have been asking as a common question regarding any form of cervical cerclage is that when we are taking this cervical cerclage, how early can we take it? See, we can take it as early as 10 to 11 weeks. The reason why people want to take it at 10 to 11 weeks is because after the nuchal translucency scan and early anomaly scan is done by the fetal medicine person, and once they gives you a green signal that okay, go ahead and take the sutures, there is going to be no early anomaly. So that means the chances of having late anomalies are not so high. Okay, so that is the situation when you can do your early cerclages. The late cerclages can go up to 24 weeks, 25 weeks also, because it's predominantly going to be dependent upon the amount of funneling which has been experienced. Somebody had asked me a question which I will answer. Do you routinely do it for all twin IVF gestations? So I was doing it, okay, for all the twin IVF gestations, but somebody had done a court case against me that it is not justifiable and it is unethical medical practice, because one of my patients, after I had done a twin cerclage at 19 weeks. Okay, it was a prophylactic cerclage. I had done a McDonald cerclage. The patient went into preterm labor at 27 weeks. Okay, and then somehow people tried to correlate it to the cerclage. Nothing happened. I did not have to pay any compensation because it was ultimately proven as a preterm labor. But since that day, I decided that okay, unless there is an indication, we will not be doing it even for twin cerclages. I mean, even for twin pregnancies, even if it is IVF. Okay, so I don't do it. Okay, for twins also. But as a referral unit, I end up doing a lot of emergency cerclages when there is funneling at the internal os. Okay.
Do you check for the placental location
Yeah.
before you put
In
the
fact, I had
stitch?
called you yesterday only, no, to check, because see, one of the patients, the placenta was little low lying, and that low lying placenta was also having just touching the internal os. But what had happened is the cervix had opened up. So in this situation, you have to go ahead and explain this risk to the patient and do the procedure. I don't think it is a contraindication. I just wanted to verify it from you that officially I can do it or not. Nothing else.
No, yeah. So once you cut the UV fold and you're trying to take the bite, if there is bleeding, okay,
Yeah.
because the needle is quite thick, and when you try
Yeah.
to bring the tape out, then that also, like, kind of starts bleeding because of the edematous tissue. So
Yeah.
do you think you had to use at any given point in time, like, water clot or any kind of
So
hemostatic?
So honestly, if there is a spurter, one can use bipolar, because using bipolar over a pregnant uterus has got no problem. Understanding. So we can use a bipolar if there is something like this. Correct. If you think you don't want to use a bipolar and be super safe, you can use a vicryl stitch approximating the vessel, so that bleeding will any which ways close. It will go through the cervical stroma, but the bleeding will close. But if there is something like this, we prefer to use the bipolar. Nothing happens, honestly.
And when do you remove the stitch? I know, I mean, you don't really, like, do a lot of deliveries, like it will be a referral. So you will send back to the primary consultant. But
Yeah.
ideally, what would be your suggestion?
See, most of these people end up with a cesarean section, is what I have seen. Okay. And when they do a cesarean section, we recommend to not remove that knot. See, if we have placed it laparoscopically, then to 100% we want cesarean only. Don't remove the knot. That knot will stay for the next pregnancy also. Understanding?
Yes.
If we are put a Shirodkar like the one in the video which I showed, then also we recommend to put a cesarean section, because that knot really holds. By the time you reach the time of cesarean, no, it will be buried inside the cervical stroma. The cervix would have become more bigger in size, more edematous in size, and the knot would have got buried inside. Okay, so I don't recommend any form of removal unless the patient is having continuous vaginal discharge post delivery. Okay, unless there is a
Okay.
situation like that, we don't recommend.
So, have you used Prolin or Silk like before, like in the beginning of your practice, and then shifted over to the tape?
So we are on to the tape since the last 2.5 years, only using the tape and only almost doing Shirodkars. I mean, modified Shirodkars. We somehow feel that the benefit of going close to the internal os is much more profound. Okay, see, when something is 16 weeks, 18 weeks, something like this, no, then we will put it laparoscopically only. Now we are not even doing it vaginally. Even if it is primary thing, we want to put it laparoscopically because we are at the os. Okay, then nobody can challenge you in any court of law. Nobody can challenge the expertise that, acha, how can you do, and all these things, all that nobody can challenge. Okay, so that is the best in my opinion, because that is the most thing closest to the internal loss. Okay. The next best is to do a modified Shirodkar where you are not at the internal os, you are just below it, but that 5 mm tape will take care of that distance of 5 mm. Understanding? And so we have shifted exclusively to Mercilin tapes. And in between, Mercilin tapes were not available in the country, and they were, so we were a stockist. So we had around 100 that time. But so around 30-40 were taken from us, but it was good. I mean, we've never faced a shortage after that.
So with the silk suture, have you noticed that there is increased vaginal discharge and more chance of vaginal infections compared to the tape?
No.
Not really.
No.
Okay. Have you seen any bucket handle tears wherein you failed to remove the stitch and patient went into labor and it came out through the posterior cervical lip?
No.
Okay. Yeah. So while removing, I mean, if there is difficulty, as you told, like, McDonald's is quite easy to remove. Modified
That is because it is
Shirodkars may
outside.
be
No, McDonald's is
outside.
outside.
So, but modified Shirodkar may be a little tough to remove. So, do you think, I mean, you really need to remove the stitch in case if the patient is willing only for vaginal delivery with all the struggle, like,
Counsel the patient and tell for cesarean, yeah. They will agree what vaginal delivery you are talking. They will agree, yeah. You have to counsel very nicely. You have to
no,
just
you
tell.
can't say that. No, you can't say that. You should just answer. You can't say you will do a cesarean. You should say, like, if it is difficult to, how can you say that? I know
That is
you
what
have
people do,
100%
madam.
cesarean rate.
No, that is what people do, right? If there is a Shirodkar stitch, you tell the patient, this is more safe for your child and for you. What her entire family will undergo cesarean. Understand? You can't
You
say
can't say
that,
all these things. No, you can't tell that. Okay, it's okay. Post this thing, I mean, till probably like 14 weeks, do you think progesterone is a good drug to give as tocolysis? I mean, do you believe in it?
It will not work, madam. The problem is after that luteal placental shift is occurring, maybe 9-10 weeks, after that window, the amount of progesterone which is secreted by placenta is so huge that it has got our external progesterone has got nothing, no significance in front of it.
Okay, do you put this Clinton vaginal pessaries the night before the procedure?
No, no,
Do you give probiotics to the patient post procedure?
no, 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 no.
Okay, so how do you rule out chorioamnionitis in case, like, in your cases where they come
So
in emergency?
all patients at admit when they come in emergency, only CBC CRP is done. Normally, in a pregnant lady, if CRP is more than 50, that is an indication that some amount of uterine infection is also setting in. Okay, that is when you need to shift the patient to 3 days of IV antibiotics, because just Clinton vaginal pessary will not work, madam. Chorioamnionitis is deep-seated infections. You need IV antibiotics for such type of things.
Okay, so yesterday's case which you had put up in the group, that was around, say, 1 centimeter, it was open and we could see the
Yeah, yeah, yeah,
membranes. So
yeah, yeah,
maximum
yeah.
up to how much dilatation have you
Full
put?
dilatation. Yeah, full dilatation. You can that lip, that cervix lip, when it becomes what is it called? It goes up. Recedes. Huh? No. What is it? Efface. It is effacing. No, that cervical lip is getting effaced. No, when it becomes very thinned out, you can hold that thinned out lip also. Put the membranes inside. Give a steep head low temporarily for 30 degrees. Okay. When you give that steep head low and when you push atosiban, uterus will relax a little. Okay. In that membrane will go inside. Once the membrane goes inside, in that situation, you will have to open anterior pouch, posterior pouch. Okay. And you will have to put Mercilin tape very close to the internal os.
Have you
We've
done
done
that?
that. We've shown that I think on videos also, probably.
Okay. So in such cases, I mean, there is a theory which says that you can put a Foley's bulb and try and push it and
You can,
or
yeah.
a wet sponge.
You can put a Foley's bulb, try and push it. The problem with Foley's bulb is if you inflate it very much more, okay, then the membrane has a risk of getting broken. That is the problem.
Yeah.
And if that membrane breaks, then nothing will work. The child will deliver out. So we have to be very careful in that. We have to tell the patient that 50% failure rate is there when there is full dilatation. 100% failure rate when you have fetal parts in the membrane outside the vagina. Because once you have fetal parts coming there, it's very difficult. Fetus will keep on flexing and moving, and that will cause the membrane to start leaking. So it's very tough.
So when say that the stitch is a failure, as in because see, this is a mechanical problem.
It will
Okay.
fail in the
So
first
which are
48 hours, madam. If it is to fail, it will fail in the first 48 hours. Membranes will give way. It will be leaking, or it will give way on table only, in an emergency cerclage.
Mhm. So, what is your success rate? I mean, amongst so many hundreds that you have put in your career, so how many of them have successfully continued beyond salvaging, like beyond 28 weeks?
So this year we had one laparoscopic cerclage which we had done in Pune at 19 weeks of gestation. The patient had 1 centimeter cervix, mouth completely opened, everything pulled up. We did the cerclage. She lasted 7 days after that and it failed. Okay. And that was the problem. But apart from that, in this year at least, we have not had a failure. So we have done so far. Thanks to you, I had to calculate. Visma had to calculate the data today in the morning. So this year we have put 122 cerclages. Okay, and this is one which has failed in Pune. But out of this 122, only 4 has been sort of only at funneling. Everybody else is at short cervix, opened mouth, and all these things. So outcomes are pretty good. I think the importance is how you standardize the technique, which is what people don't understand. See, you must push that vagina up from the anterior cervix. You must do that. If you are able to do that, then automatically you are ensuring a 2.5 centimeter length of the cervix any which ways, and all these whatever RCOG, BCOG, TCOG, whatever
No,
guidelines you
don't
are
say that.
talking is
See, I think,
2.5.
yeah, yes,
2.5.
yes.
So when you cut off that window of 2.5, okay, you are establishing a very good outcome for that particular patient, which is the take home point.
Yeah, I think the challenge is in the anterior suture because the anterior lip is quite short. So,
Yeah.
as you said, I think once we open that UV fold and once we ensure that there is more than 2.5 centimeters length, I mean, that gives a lot of
See,
support. Yeah.
main problem people face is because of not passing the suture there. Main problem people is worried is because they are worried that if they pass the suture and what happens if the suture goes through the bladder. Okay, that is the mind fear. Irrespective of what people tell or not, it is in their mind. It is fearful that if in case something happens to the bladder in pregnancy, then what? Okay, so learn to dissect the anterior vagina. Just dissect the vagina. See, what we are doing is we are infiltrating in the vagina. It is not going in the bladder. So what swells up is the vagina. Bladder never swells up. Correct. Bladder will absorb the fluid, if at all. It is straight into the musculature. Correct. So what will happen is when you cut through the knife, you are cutting the vaginal wall. You are cutting the vaginal margins. And then when you use your speculum to push it up, de facto, okay, that little part of the bladder gets pushed up. You will see the cervix only. That is how it is. Okay, and that is something which you have to keep in mind, because it will help you allay your fear and you will be able to put your stitches any which ways higher up.
So, have you come across any referral case where the stitch has been passed through bladder and have you
Yeah,
had to
so far
remove
we
it?
have operated 5, okay, in our career, where the cervix, I mean, where the stitch has, no, and it can be any stitch, okay, Mercilin has gone through bladder, Mersilk has gone through bladder. But the problem with all this is, no, that rent is very big. It's not a very small rent. See, what happens is you will realize that it has gone through the bladder very rarely on the same day. Okay, in that pregnancy edema, people don't realize it on the same day. Patient comes back, okay, with discharge from the vagina, which is urine, and you realize it after 15 days, 7 days, 8 days, like that. So what people don't understand is in that situation, that tape has caused a huge amount of necrosis there. That base of the bladder is completely necrosed. Okay, in that particular type of a situation. All right. And in that necrotic bladder, already there is so much edema. Going and operating is a very, very difficult thing to do. Very, very difficult thing to do. So in that situation, you have to pray that it is not the Mercilin tape and it is just silk. which has gone through the bladder, which is causing the least damage. Even lesser damage will be caused by proline because it is a monofilament, right? But Mercilin tape, when it goes through the bladder, it causes a lot of damage to the bladder.
Okay. Have you packed the vagina post procedure any time to control the bleeding?
Actually, madam, if you give pressure over it, correct, for a particular amount of time, let's say 2 minutes, 3 minutes, whatever, that bleeding will really stop. Okay, it will not, unless there is a pumping vessel. If there is a pumping vessel, if there is a spurter, as I said, either you bipolar it or you take a stitch. That time your pack will not help.
See, the problem is like, I mean, in prophylactic stitches in pregnancy, there is that ectopy or the erosion that you see. And once you try and catch it with sponge holder or with the Alice, there will be like generalized ooze.
Yeah.
Which is a little tough to like manage. And so do you recommend packing in such cases for say like 6 to 8 hours, or it really doesn't matter? It stops on its own.
Yeah, it just stops on its own, madam. There is no requirement to do anything. It will stop on its own. It will stop on its own even if the patient is on ecosprin and heparin. That is again something commonly people ask in pregnancy.
Mm-hmm. So you don't stop heparin and ecosprin while you are putting the stitch?
How? No, madam. These are emergency patients, most of them. What we will stop?
Okay. Yeah, thank you. I think it was good. I think you should get back to your OT list. I know you have a long list. My regards to everybody in Glen Angels at Chennai. It was very, very good session. I thank you for taking out time from your long list to give this lecture, because many, many questions were asked after you posted that video yesterday. I think majority of it we have covered. If there is anything at all, I think we will take it up in the groups. So yeah, have a good day. Have a good day to all the other consultants who have come in from
They are
Coimbatore.
sitting like first standard senior KG students and listening to you. See, yeah, I'll show you. See what they are doing. Poor guys. They are all sitting in like first standard students and listening to you.
Hi, Madam. All the very best, madam. Don't torture anybody, madam. There. Thank you very much.